for a few minutes and let him come to the on screen. Okay, I'm not audible. Hello. Now, am I audible? Hello. Am I
Hello.
audible?
Yes, I can hear you.
Yes. Okay, fine. But I'm not able to see you. Maybe some. Maybe you have to switch some camera.
Camera is on already. Can you see me now?
No, I think the
No.
direction of camera. Yes, yes. Now I am able to see. Okay, fine.
Oh, great. Yeah.
So very warm welcome, Dr. Chandrakant, for your prestigious time to discuss about the McKenzie approach for the neck pain. And Dr. Chandrakant has passed his bachelor's in 2010, and he completed the certified diploma MDT in 2012. So now he has also presented in 2019 the paper regarding the tendinopathy management from McKenzie Prespective. So again, I am welcoming to you, and today he will give us some insight about how the McKenzie approach works for the neck pain. And it is very common. We routinely see a cervical spine pain patients in our practice. Many of times we see that the person is presenting with the radiculopathy along with the disc bulge and all this stuff. So just tell us now, how do you approach for the patient from the history point of view? What are your $1,000,000 questions that you ask in your examination? Like when you are specialized in McKenzie. So in McKenzie, what are the special questions?
First of all, thank you so much, Dr. Jamin, but for inviting me for the talk on the McKenzie perspective for the neck pain. So any patients who comes to a McKenzie clinician, so we McKenzie is actually a set protocol who has an assessment, diagnosis, and treatment. The name itself is a mechanical diagnosis and therapy. Means the body itself is a machine. So we do an assessment, we take the history and the physical examination, which is a part of the the assessment process,
Okay.
and whatever outcomes we get from the history and the physical examination, accordingly the clinician proceed further with the line of management.
Okay, so what are the like in our practice when the patient comes to my clinic with the cervical spine pain? So I will ask about what are the aggravating factors and relieving factors and which moment he or she doesn't have a pain. So do you have any specific questions that you have used in your clinical settings that you can find it out this patient suits in the McKenzie approach?
Yes. So in the history section, we have a body chart which direct us like what will be the location of the pain. We get to know the duration of the pain, aggravating and relieving factor. We get to know the past history. We get to know the past treatment protocols, whatever treatment he had till the date. Then the symptoms, like the severity of the symptoms, whether it's constant or intermittent. So like that, we ask various questions, and at the end of the question, like history section, we have a specific questions which helps clinician to get to know the information. Are there any serious pathologies? So there are specific questions which helps clinician to whether to know whether is there any specific pathology or no. So if there is any specific pathology we clinician find in the history section, then the clinician guides the patient accordingly. And if it's he gets some clues, then sometimes the history also guide us. Yes, we can proceed with this patient, and we get to know with the physical examination. And after doing the physical examination, there is a movement testing, which is a sense of the mechanical diagnosis and therapy. So in that, even if the patient has a no pain, okay,
Okay.
and but the patient is suffering from the pain in this present episode or duration.
Okay.
So in the detailed history, we get to know overall insight about the pain. So accordingly, we check the movements of the cervical spine, and after checking the movements, we get to know his baselines, like his pains, his duration, and the symptom, the intensity of or the severity of the pain. Accordingly, we proceed with the repeated movement testing. Now, the repeated
Okay.
movement testing, okay, tells or gives an insight to a clinician like what exactly is happening with this certain movement. Like, say, for example, maybe a protrusion, maybe a flexion, or maybe a retraction. So, this analysis of these movements, okay, we have a traffic light guide which on every movement of the repetitions of the movement we get to know whether what's happening to the with the symptom, whether increasing, they're decreasing, they are no effect. So accordingly, the clinician proceed further, and at the end of it, we get then conclusion. Yeah, this could be the probably the diagnosis.
Okay, fine. Yes, that is very good things. But you have also mentioned the specific questions. Like when the patient comes to me, let's an example. He said that I have pain in extension, only extension I have pain. So that will help me to identify if the person may have approximation issue, or he may have a converged pattern or divergent pattern of a movement. So in your assessment, do you focus on a specific questions in every patient? Like I have a specific questions for the neck pain. So from the McKenzie point of view, what are the specific questions that will help you to identify this person may suits, and then you will go for the repetitive testing of retraction, protraction, or side flexion, or for flexion extension like this. Just
Yeah,
just, just
that
give
is
us some brief idea.
Yeah, that is called as a directional preference in the McKenzie method.
Okay.
Directional preference means the in the direction where the symptoms are going to get reduced, or we are going to get the favorable response. Means that patient is going to respond to the exercises. So sometimes some patient, it's not like every patient will give you a directional preference in the worst better section. Some patients do not give a directional preference. So in
Okay.
those kind of patients, we have to do a repeated movement testing in both the direction. So it may be a flexion also, it may be extension also, it may be a retraction also. And the analysis of that, for example, after doing the flexion, what's happening to the symptom? After doing the extension, what's happening to the symptom? After doing protrusion, what's happening to the symptom? So analysis of those repeated movement testing response or the result guides the clinician like, yes, you can go with this patient, you can go specifically in this direction and you will get the results.
Okay, fine. So that is very good thing. And now most of the cases, patient comes with a radiculopathy as well
Hmm.
as on an MRI. They MRI showed about the disc bulge at the C3, C4, or C5, C6 with respective the dermatolome affection. So how is your approach in that type of patient when the patient comes with a radiculopathy?
Uh, yes, good question. So, any radicular pain when we receive a patient, as we go with our history and the physical examination section, we also do try to screen any serious pathology is there or no. We also go through a patient's MRI report, what MRI reports are saying. But when there are no MRI reports, we need to go to the our history and the physical examination section. Then there is a movement loss section, and the we also do an neurological evaluation where with the radicular patient we do muscle testing with the strength of the muscle, sensory or the motor. Then we check for the dural signs, any positive dural sign is there or no, and accordingly that guides the clinician. Like this could be the baselines. Means there are some patients, they display some kind of weakness or some kind of maybe motor or sensory loss. So we take them as a baseline.
Okay.
We take them as a baseline. For example, if any muscle weakness is there, we take that as take it as a baseline. And after doing the repeated movement testing, we check those baselines. Sometimes the muscle weakness or the muscle weakness is due to the pain induced.
Okay.
Means because of the pain, patient is unable to do the movement, and generally we consider as a there is a strength deficit. But in MDT, in the McKenzie method, after doing the repeated movement testing, we again cross check with those baselines of the the strength testing, and we get to know sometimes after doing this repeated movement testing, when we get the directional preference exercises, the pain induced pain, the baselines recovers and the patients get back to the normal strength of the muscle. Secondly, the radiculopathy pain also, responds in very different way. Where the in a McKenzie, the radicular pain is a diagnosed after the repeated movement testing. Okay,
Okay.
generally in the radiculopathy, what we consider the pain is coming radiating down to the hand, right?
Okay.
And we generally diagnose as a radiculopathy. But
Radical.
yeah, but in McKenzie system, what it happens when the patients come to you with the radicular symptoms,
Okay.
any MDT clinician will take a history, physical examination, will do a repeated movement testing. If
Okay.
his radicular symptoms improves or responds to the exercises, then it will be classified as a derangement.
Derangement. Okay.
Derangement is, so McKenzie has its own classification system, whether the derangement, dysfunction, or the postural. Derangements are the rapid responder. Dysfunctions are little slower responder, and postural symptoms are associated with the postural activities, positions, and the movement. Okay. So if the radicular symptoms response in the day 1 or within consecutive session 5, let's say 5 or 7 session, then it will be diagnosed as a derangement syndrome. Okay.
Okay. Yes.
So that is called as a responder. But if the radicular pain does not respond, okay, then the clinician will go with the further evaluation, like what all things are necessary, and accordingly, then it will be classified as a non-responder or mechanical unresponsive radicular syndrome. So when it comes to the mechanical unresponsive radicular syndrome, it will be treated and guided according to the McKenzie protocol. So generally in my clinic, if the majority of the radicular symptoms, they suppose those whoever are responding, the response is decrease no better, decrease no better. But overall, if the status of the patient is improving, then we generally advise patient to do general functional activities and the exercises, and gradually the patient improves. But if the patient is not responding or getting non-responding, then it depends upon the pain scale of the patient. If the pain scale is more than, like VAS score is more than 5, then we advise the patient maybe for the epidural injection or for the maybe. But that we do not take the decision. We generally refer the patient to the orthopedic or the neurologist, and then he or she may take the decision to this patient. So accordingly,
Yes.
we guide and guide
As
the
you
patient
said,
with the radicular symptoms.
yes. Because whenever our treatment doesn't suits in the patient's framework,
Yes,
then we have to refer
yes,
them. But
yes,
as you said, when you are doing the repeated movement and patient is getting better, if we look at the literature, as MDT is very effective for the neck pain. Okay, but there is very lack of evidence which is supporting to the MDT exercise. So what is the effectiveness when you are treating with the neck pain for the McKenzie method? So what is your opinion for that? Because I have read many papers that they are saying only 60% or 70% is reliable when you are treating the radicular symptoms with the neck pain. So
yes.
just tell us from your point of view.
The reliability of the MDT system, it depends upon the clinician who is assessing and treating the patient. So the reliability differs with the level of the education in the McKenzie system. Like the diploma has a highest reliability, the diplomats and the clinician has a little lower reliability, and those who are not aware about the system, they definitely have a further lesser than. So the people or the clinician, those who knows what is the system about, there are high chances. There are good certified clinicians also, not necessary to be a diplomat, but there are good certified clinicians, though who treat or assess the patient with respect to the McKenzie way, and they are getting the good results. So it's about this is not the like a set protocol or
Yes.
the McKenzie exercise. You have to do this, we have to do this. This is a system where we have to analyze or understand the depth of the system.
Yes.
If
Correct.
you work or the follow the system with its pathway, definitely you are going to get the result. The way you were said that 60% are getting better, 40% are not getting
Yes.
better. Yeah,
60.
yeah. The reason is that the 60% are falling into the derangement.
Hmm.
40% may not be falling into the derangement. So that's what the McKenzie system is about. The system, like if you get 100% of the patient, 100 number of the patient, so when each and every patient will go with the MDT evaluation,
Okay.
McKenzie will try to diagnose this how many out of 100 are responder and how many are a non-responder.
No.
So as per the literature say, 70 to 80% of the population will have a directional preference. Means those will fall into a responder category. Those who do not fall into the responder category, those are 20 to 30%. So those fall into a 70 to 80% of responder category. They have the McKenzie's exercises, which the results are robust and patient get better within 5 to 7 sessions. Some patient may take a little longer time, but the results are good and they are responder. Means they are going out of those 60%, definitely or 100% they are going to get better. So remaining 40%, those who are non-responder, so they'll have to guide or treat accordingly. Means some may need some kind of like for example any epidural or maybe any other therapy. There is other one more aspect in the MDT which I would call it as the biggest different ocean than the MDT. That is called as a biopsychosocial model. Like
Yes, correct.
that is, yeah. So we generally clinician just think of, he may be having the some kind of PSY issues and all. But how do we address that? That is also more
That is
important. And here, yeah, because generally here the MDT teaches you like how to guide, advise those patients, those who are falling into this biopsychosocial or the PSY factor. Like I'll tell you the recent one of my patient. Uh, she has lower back pain radiating down to the leg, and the MRI was suggesting disc prolapse. The protrusion is there and everything is there. That patient had gone to a I was the third physiotherapist. Okay, already she had gone to the two physiotherapists. Both of them treated her exclusively using all their techniques, all their modalities in their clinic, and then finally the patient called me and she had an assessment with me. After the assessment, I got to know this is not at all these symptoms are radicular, but she is not fitting into that category. So
correct.
the more psychological aspect is more dominating rather than the pain. The patient asked me the question, doctor, there is a no, my MRI is saying that. Then I quoted her with the reference report that there is a study which says that whatever we see in the MRI is not necessary to give you the symptom. That's not the root cause of your symptom. Here, she was afraid of doing the flexion. She was being told not to do a flexion because if she bends forward, she's going to get the slip disc and slip disc is going to get worsened. I started with the flexion. Before that, it was a huge task for me to give an education about. I explained her MRI, how it is, and I explained her how the McKenzie method is going to help you out with the help of traffic light guide. So I started with the flexion. She it was an equivocal response to the both the flexion and extension. I gave her as a flexion exercises. Okay, she after 2 to 3 days she came to me. She said better. I'm a better.
Okay,
Okay,
that's good.
I advised her to continue the exercise for one more week. Since she was better, I do not wanted to change it. I gave it for one more week. She said further better. Okay. So then I explained her. Okay. This was the flexion exercises, like how generally it works on the spine and all. Then I gave her extension exercise. She also felt the equivocal response. Then she asked me how is the psychological pain and all those things. Then I quoted her with the research report that this is
That's
a research report how it says about the psychological pain. Psychological pain doesn't mean that patient is a psycho.
yeah.
It's about your how you think, your attitude, your behavior, your thinking, your perspective, all are linked to the pain and how the pain pathways work. Then patient started getting understanding and now she comes hardly once in a month. When I have told her very clearly, like whenever you have pain, you can just come to me. Otherwise, that's okay if you just continue your exercise. She has started her running, jogging, yoga, all the activities.
Yes, that's nice. That's very interesting thing. And just you told
Yeah.
about it is very difficult for you to make the patient understand what is McKenzie and what is the approach what you gave to her.
Yes.
But from the patient's education point of view, how you approach to that patient, because it is very common for us that it is difficult to find it out. The person has a psychological issue or the person has a specific radiculopathy, or sometimes patient has a back pain, knee pain, ankle pain. He comes with the whole orchestra and which कहाँ से क्या होता है वो हमको भी कभी बार मालूम नहीं रहता है. एंड बेसिकली आपने
Right.
क्या कौन सा आपने क्वेश्चन और आपने कैसे पेशेंट को हैंडल किया that the patient will understand your thought process and he started doing the exercise. Just give us some brief idea.
Yeah. It's actually again it's a very deep question actually, but
Yes,
I'll
yes,
just give you an overall view.
it's a very deep question, but just give some lights, because see, it is very difficult for people to make the to understand them. They have a psychological issue. Yes, you have done fantastic the patient education. So in patient education, what is your checklist? What are the things that you have entered in your patient education checklist that will help the patients, and it will help your treatment guideline, because you have given only 2 days flexion or extension exercise, and after 2 days the patient will get recovered.
Yes.
So just
So,
tell us about it.
yeah. So it wasn't only a flexion and extension exercises. I did a complete thorough evaluation with all the repeated movement testing
Okay.
using my hands-on techniques. It's not only a, it's not, the protocol is not only to do a flexion or the extension exercises. It's about also to do a patient for, exercises with the patient generated forces, clinician generated forces, clinician
Yes.
mobilization, all the static movements, the dynamic movements. We have to complete all the protocol, and the yes, the response of this all the procedure like patient exercises, patient generated forces,
Okay.
clinician generated forces, or the mobilization, that helps or enables clinician to get to know the desirable diagnosis. Now the
Yes.
similar patient, just last week only she came to me, similar patient, same patient, she came to me for the neck pain. You know what question she asked me first? Doc, is it a mechanical or non-mechanical according to you?
Google doctor. I
So
give
I
those
told
patients the
her,
label Google doctor.
yeah, yeah. So I told her, this is just the first session. Let me just go through one or two more session. It was a kind of, psychosocial, just because of her, because she had a traveling and all. So with, again, I told her, let me just go through 1 or 2 days of more, evaluation, and will definitely will guide you. And yesterday only she called me. She was better with the exercises. So I think it is a mechanical.
It was good.
So yes, so in this McKenzie system is the clinician has to understand the essence of the system. He has to or she has to go a thorough evaluation of the history physical examination and the repeated movement testing. The repeated movement testing is a key to the diagnosis that helps the clinician to diagnose. Like in the derangement syndrome, it's all everything will get, the faculties of the McKenzie Institute, they guide you to the participant, like what will be the response to the derangement syndrome, what will be the response to the dysfunction syndrome, what will be the response to the postural syndrome, how you have to diagnose if it's not derangement, how you have to classify into the other subgroup, and which other subgroup it would be. So that's a whole lot of evaluation analysis, a lot of clinical reasonings are there. So that helps the MDT clinician to diagnose the case. Like I do receive a patients to my clinic, those who directly referred from the orthopedics as well. And as we are aware about in the physiotherapy, that orthopedics are generally all the treatment is prescribed. You just
Yeah.
have to be a mediator and you just have to follow that,
Hmm.
right?
Yeah.
Like correct me if I'm wrong. So like patients come with the dithermy bola hai, TENS bola hai, IFT bola hai,
ट्रैक्शन
and this
अल्ट्रासाउंड भी
traction
बोल दिया
bola hai.
होगा.
And some patients are very, interestingly, they also did a timing also.
हाँ.
Then I ask them sometimes, didn't they tell you about the frequency also?
हाँ. हाँ.
So,
सब डिटेल जानना.
yes. Because some patients are, they are very tricky. They always try to play with you. I want 15 minutes or 20 minutes. But all the patients, those, whatever there was their diagnosis, when they come to my clinic, I do listen to them. I look for their at the reports, but I go through my McKenzie evaluation, the history, physical examination, repeated movement, and whatever outcomes are coming after the repeated movement testing, I just share those outcomes with the patient. If they are going to respond, then what will be the line of management? If they not respond, then what will be the my guidance? So that helps the patient to get, to maintain that transparency between the clinician and the patient, and patient automatically gets open up to the clinician or the doctors. Otherwise
Yes.
patients are sometimes very skeptical to share their thoughts also.
Yes.
So this also, it's really interesting to get to know your patients are getting open up to you, and they share their all the information with you.
And the one thing is that how often do you use a mobilization or a manipulation in your patients? And how do you differentiate? There are specific techniques, or you have an assessment, articular dysfunction or a myofascial dysfunction. So just tell a brief about it. How, when to use mobilization, when to use the muscle release and the repetitive motion and all this.
Yeah, so all the techniques or the procedure in the McKenzie method are meant for two outcomes. First outcome is not for the treatment, is for the diagnosis. For example, when we give an exercise with the patient generated forces or clinician generated, like clinician overpressure or mobilization, we do analyze what is the response is happening during that and after. So we have the baselines we take, the, like as I said earlier, the muscle weakness could be a baseline. So like that, the clinician is trained very well to get multiple direction of the multiple baselines. So after the repeated movement testing, when we get to know the response, we again cross check with those baselines, and we see the when we see those baselines are getting improving, that's classified as a derangement syndrome. So everything, like all the procedures whatever we do, first is try to analyze what is response, like for example, if I'm giving mobilization to a patient, so I'll take the baselines. I will see to that what's happening during the mobilization, what is happening after the mobilization, and I'll again cross check with the baseline. So when the baselines are improving, so that will help me get to me know that these baselines are improving, so the patient is responding well to the mobilization. So when the patient is responding to a mobilization exercises, there are the exercises which can be given as a home exercises that will be parallelly work as the effect of the mobilization. So patient here is a self-empowered to doing the exercise also. Like for example, what happens in the manipulation, we do a technique, okay, we do a thrust, okay, and the patient we send to the home. Patient generally I haven't seen given exercises after the manipulation. Here the exercise even after the manipulation also, or clinician procedures or technique also, the exercises are given equivocally or parallel equal exercises to get the desirable responses with those exercises. And frankly speaking, manipulation generally has been taught at the diploma level, at the highest level. So I learned manipulation techniques in my in my clinical practice, sorry, clinical component. But till the date, I haven't used it on any of my patients, because majority of the patient gets better with the my hands-on procedure only, with the clinician or pressure or the mobilization. So it starts with the patient-generated forces, clinician-generated forces, then clinician mobilization, and then the manipulation. So patient get better at second and third level only. Max to max, we have to reach to the clinician mobilization, but manipulation I haven't used, and I haven't seen any of my colleague, or they have talked like today I use the manipulation
Okay.
techniques. No, but
Nice. And,
it's, yeah,
and
because
once,
it's
yes, yes.
the McKenzie also teaches you a safety guard,
Okay.
because suppose I'm giving manipulation to any of the patient, so there is a MDD set protocol, like who will be the true candidate for the manipulation. It's not like every patient we are coming and we are
Perfect.
giving the manipulation. So it helps you to identify the true candidate for the manipulation. If that patient is fitting into that manipulation criteria, clinician is have a green signal to go ahead for the manipulation. So, like for example, if some patient is coming to you and he has osteoporosis in the middle age also,
Hmm.
sometimes patient do not tell to this to the physiotherapy because they don't think it's important, or sometimes it's missed by clinician or missed by the patient. And a manipulative therapy comes into contact and gives a manipulation. What happens if the fracture happens?
Yeah.
The
That was,
clinician into a trouble, isn't it?
yes,
Right?
that
So
happened.
this mechanism system has a safety guard for the clinician as well as the patient. So after getting to know the response, desirable response, then the clinician can go ahead whether the manipulation is required or not required.
Yeah, yes.
But as I said, majority of the patient gets better with the clinician mobilization procedures only.
Okay, fine. And what is the criteria when you want to start a neck strengthening exercise, and how much give you importance about the neuromuscular control for the neck pain and for the neck pain patient?
Oh,
Once
that's
once we are abolishing the pain from your McKenzie point of view,
yeah.
so now it's part of a strengthening as well as improve the neuromuscular control.
This
So
is a very good
what is your
question you asked. Yeah. Yeah, that's a very good question I asked. I would say that, see, many of the patients I received to the clinic and they said, my neck muscles are weak. Okay. Generally, I'll ask you, how many of the population, or let's say, how many people go to the gym? Let's say out of 100 people are living in your area. Out of
Yeah.
them, how many goes to the gym? Let's say it's 50%. Okay. Out of those 50%, how many patients do their neck strengthening exercise in the gym?
Nobody.
Exactly.
until
Even though I
until
go to the gym,
they don't have a third, fourth, or fifth episode of neck pain, they don't come to our clinic or any. They don't go for any healthcare profession.
exactly. So that means those who are doing the neck strengthening exercise, they should not get pain because their neck
No, they
muscles
will
are
get the pain.
strengthened,
They will
isn't it?
get the pain. As for the
Why?
literature, Jule et al., they did the study and they done in, I guess, in 2008 approximately. I don't actually remember the years, but they already said that until and unless, even though you are going for the neck strengthening exercise, the second time neck pain will come. That is for sure. But there is
Exactly.
no specific time frame. It will come after 6 days, 6 months, or 6 years. But patient don't get relief with the neck pain. But here, what we want, the same complaint will not occur. So we want to work
Yes.
on the prevention part.
Right. So the strengthening is a valid exercise?
Strengthening exercise, see, it's not about the valid, there is not the validation and any reliability. It is about to maintain the control as well as to do the movement very efficiently and smoothly. It is about the neck strengthening, because until and unless if you remove the pain affects the slow motor unit, and it also affects the motor control, even a small amount of pain. So we must do the neck exercise as well. So you
Right.
have abolished the pain from the repeated flexion or a McKenzie approach. So now about यानी कौन सा स्पेसिफिक आप टाइम फ्रेम चूज करते
Yes.
हो, कब कब करते हो
Yes.
कि अभी से नेक स्ट्रेंथनिंग शुरू करना चाहिए और अभी से नेक न्यूरोमस्कुलर एक्सरसाइज आपको शुरू करना चाहिए.
Yes. Now I got to the point. See, now as you said rightly, that once the pain goes away, we can start with the strengthening exercises. Okay. That means we have to classify the patient first for reduction of his pain. What would be the line of management or the treatment? Once the pain reduces, the McKenzie has a protocol like that falls into a derangement category. So first principle of line of management is a reduction of derangement. During the treatment, it's maintenance of the reduction, and then the prophylaxis or the prevention of the recurrences and the recovery of the function. So MDT, start the strengthening exercise. MDT, I do give a strengthening exercise to my patient, those whoever required, but that comes under the recovery of the function. Like when the pain, everything goes away, first of all, when the patient stays better without a pain for a week or let's say 3 days, at least 48 to 72 hours, depend upon the previous past severity of the symptom. And accordingly, we start with the strengthening exercise. So in that sense, in the recovery of the function, what we call as, in that, yes, I do give patients a general strengthening exercise, those who are required or advised, shoulder strengthening, chest strengthening, back strengthening, all the strengthening exercise. So I do give a strengthening exercise. But when the patient is coming to me with on the first instance, I do not start with the strengthening exercises
Okay.
because that's directly I'm starting with the treatment without knowing the diagnosis.
Yeah.
So first, like if the muscle weakness is there, as I mentioned before, if there is a true muscle weakness, okay, then it will not respond to the exercises what we are doing. Okay, the direction preference exercise. So that comes under the others category. When the patient is responding to the exercises, automatically the secondary with the pain induced muscle weakness will always revert back to the normal state. So
Normal. Yes.
here, yeah. So here we have to work or use a system according to the patient's classification, not by generally directly starting the exercise. So here, where the MDT clinician, the McKenzie clinician would always try to work on the pain, whether he's finding responder or non. When the pain is reduced, then yes, the strengthening exercise will definitely added at the recovery part of the function, recovery of the function.
Okay, fine. So this is, we talk about the painful dysfunction movement.
Yeah.
Now, if we
And
talk
as you
about the
said,
painless, there are
neuromuscular.
two types of movement. One is painful dysfunction, and second one is painless dysfunction. So now, if the patient is not fit into the McKenzie approach, from your perspective, it's a painless dysfunction. Okay, she has some kind of different. When she is rotating on the right side, that time she feels pain. When she do the extension, but he or she doesn't have a pain. Okay, on only one direction. But I'm talking about the person he doesn't have a complaint of pain at all. But from your assessment, you find it out he has some movement dysfunction. Okay, so in that scenario, how do you approach that patient? Do you think McKenzie will work on it, or how do you implement the strengthening or neuromuscular or any type of your regime?
Yeah. So the question what you have asked is about the dysfunction. So in the McKenzie system, when the patient, like the three mechanical symptoms, one is a derangement, dysfunction,
Yes.
and the postural. Let's say postural side, dysfunction. Whenever there is a dysfunction, the dysfunction pain will always be local, and it will respond it will respond to a loading exercises in the direction of the dysfunction. Let's say, for example, if the patient is having the flexion dysfunction, patient, even if he does the repeated flexion exercise of 100 times, every time he's going to get the same intensity of the pain.
Okay.
And his mechanics are not going to change or alter after the repeated movement testing. Okay. When he does the movement in opposite direction, let's say he does the extension, he will not get any kind of pain. So that is a particular so McKenzie has its criteria to classify the dysfunction. So that patient, and also yes, the history, physical examination, all these things are very much important. Then only we reach to the classification of the dysfunction after ruling out the derangement. So when he fits into a dysfunction category, yes, the McKenzie clinician treats according to the line of management of the dysfunction. The other patient where you said that patient do not have any pain, but still patient is having some kind of discomfort.
Yes.
So generally, as what you are saying, that patient will come in the category. Again, the McKenzie assessment will help us, but that will fall into generally a category of the mechanically inconclusive, where the patient complains of the pain, but none of the symptomatic or the mechanical baselines or response are responding in the favorable way. So when the patient comes into a mechanical inconclusive, there is a guidelines like evidence-based exercises which helps a McKenzie clinician to treat the patient accordingly. So in that also, then you can add strengthening exercises, functional exercises, general strength training exercises, a lot of exercises, aerobic exercises, whatever are suitable, cycling, gym, whatever, swimming and all.
Okay, fine. So I guess it is all depending on the assessment point of view, as you said. And from your
Yes.
perspective, Joe, now just tell us about what are the things that we need to consider for the specific for neck pain region when the patient comes to our clinic. What are the things from your point of view that we need to ask? These are the specific if you're talking about the direction preference, if the patient has a flexion, continuous flexion pain है, तो अभी उसको एक्सटेंशन में लेके जाना है, रोटेशन में लेके जाना है, कैसे, यानी क्या क्या चीज ध्यान में रखनी चाहिए, तो it is very easy for us to make the good rehabilitation regime and get the proper outcome. Just a brief.
Yeah. So yes. So like again, it has a very in-depth answer, but I'll tell after taking the history and the physical examination, when clinician get to know that the like repeated movement testing, the response is coming. So like neck cervical spine has a various movement. It has a flexion, extension, side rotation, side flexion, protrusion, extension. So whatever direction he is getting the responses. So the response is also depend upon see. For example, when I talk about the response of the pain, the McKenzie clinician would definitely address what I'm talking about. Like the person who haven't done their McKenzie. So it will be like shooting in the dark night. Where to shoot really don't know, but we have to shoot. So it will be like the situation where we don't understand exactly what we need to follow. So it's actually a system we have to follow with the repeated movement testing. Whichever direction of the movement is going to get the favorable responses, we have to move accordingly. After when we get the favorable responses, we need to also cross check with the baselines, like baselines, whatever baselines we have taken. For example, any position, any activity which is giving the pain, any sensory or the motor. So those baseline we have to, again retest it, and then we have to diagnose, and then we have to decide this will be the desirable exercise for the patient. So
Yes,
that's how the McKenzie system works.
yes.
So either it could be flexion, either it could be extension, either it could be a side bending, either it could be a rotation.
Rotation. So I guess whatever
Anything.
you said about we have to find the baseline. If we know the baseline, it is very helpful for us to get the proper outcomes.
Yes.
Okay. So now
Each and every portion of that assessment form has a meaning, has a sense and importance for it.
Yes, definitely. So what is your takeaway from this today's interaction? What do you want to convey to our listeners?
Oh, that's a really good question. I would say like whatever treatment protocol you follow with respect to your interest, I would say just think of the patient perspective. What I have learned, what we have learned in our physiotherapy academics, what I've understood that I've learned more about the exercises and yes, about the electrotherapy. Okay. Yeah. So in my clinic, I always see, it's nothing like I don't give electrotherapy modalities to the patient. Okay, I do give electrotherapy modalities to the patient, but the ratio, if you see, I would say 95 to 98% of the patient they get better with the exercises.
Yeah.
Unless and until patient do not ask to me for the modalities, I do not go for, this is the modalities, would you like to
Yes.
take? So why? Because I know the what's the use of, when to give the modality and which patient to give the modality. It's not like I have bought the modality, so each and every modality I'll start using on the patient to, just for
Yeah.
trial and error. So use your own knowledge, your own thinking, what exactly is this patient for, and do not go for the right for the classical diagnosis. Like for example, neck pain hai तो spondylosis hai, yes, yes, yes. Knee pain hai तो arthritis hai.
Already.
Always try to figure out and try to think out of the box.
Yeah.
What it could be. अगर ये नहीं
So
है तो वो है. What
it
it
could
could
be
be.
so I will put in another way. Find out not the pathokinesiological model. Find out the
Hmm.
kinesiopathological model. That will be better.
Yes, do not follow the patho-anatomical model. So MDT, in the McKenzie, that's what MDT also, McKenzie also says, right? Patho-anatomical model has, has less validity.
Yes, it's fine. So I guess it's very wonderful interaction with you regarding the neck pain, and those who are listeners and those who have joined with us, they have a very good insight about when to approach and what are the things needs to be considered when the person has a neck pain. So thank you so much, Dr. Chandrakant, for
Yeah.
your valuable time. We'll meet soon and we'll discuss for another topic regarding the McKenzie approach. And if
Yes, yes.
anybody has any questions, they can write in the comment box, and you can ask us about the neck pain.
Yeah, and I would say by jate jate ek statement like
Yeah, yeah,
yes, McKenzie have changed my life. So I wish if any of the physiotherapists, those who want to change their life perspective about the being the physiotherapy, I guess they can think of McKenzie because it's really a beautiful system. It's not like आपने कुछ answer mug up किया and that only you have to
yes.
write it. You have to think, you
It's
have to
about changing
utilize.
the views.
It's very challenging. It's very challenging. Like every patient come to your clinic, you have to use brainstorming. Every time you have to think about the patient, what it could be. What it's all about the clinical reasoning rather than just doing the techniques and the procedure. So this is a
Yes,
really beautiful concept, and I myself have changed my pathway into that very different direction, and I'm really enjoying it. It's really challenge. Every patient is giving me the challenges, so
yes,
I
yes.
enjoyed it.
Every patient is a different book. We have to
True,
read the book from
true, true.
the way.
Absolutely.
So yes,
Perspective.
yes. Thanks.
And
Nice. Thank you so much, Dr. Chandrakant, for your valuable time. So we'll meet next Friday again with this with another topic. If you want to discuss a specific things, just send me on an Instagram or any social media. We'll discuss on the your topic. Okay, fine. There is one question in radiculopathy. Does nerve flossing useful? So what is your opinion for a nerve flossing?
what kind of nerve flossing generally they are doing the treatment? See, as per the the McKenzie, I would say the line of management in the true radiculopathy is a transfemoral injection, which is research validated Hansman Halbert 2014 research paper. Like after taking the epidural injections, around 46% of the patients had recovered with their radicular pain. Means radicular pain means, again I'll tell you, those who are not fit into a responder category, those who fit into a, like this doctor bolte hai ki surgery karo, all those
Uh,
surgical candidates, there is 46 out of this 46% patient responded to the McKenzie exercise after their first episode. Hardly, I guess, 15% required a surgery. So out of 100% patient, only 15% required a surgery. So, uh, like nerve flossing and all, we need to really check with the its validity, research validity, and accordingly the clinician can proceed further. But as per the radicular symptom, yes, the McKenzie exercises and the epidural injection has research validated good results outcome.
and the second question is, if the patient is doing different direction movement, is it worsen its pain due to the number of movement? What do you say? So they want to ask something like he has pain in flexion and he does the movement in extension or rotation and the pain becomes worst due to this movement. So what is your opinion for that?
Yes, good question. So even though any pain is getting worse with any of the movement,
Hmm.
I would go back and check my baselines.
Okay.
baselines of worse better section, maybe a sensory or the motor or any other thing. There are various parameters which we get to learn in the during the McKenzie courses, like how to check the baseline. So even if the any pain worsens, like patients say when patient pain gets worse, we do check them, and are they, when these two things are really matching, then we consider it is as a worsening thing. For example, the chronic pain patient also says that pain, any moment you do activity, do the pain, their pain worsens. So that's how. So it's very analytical clinical reasoning which helps clinician to diagnose just which type of pain it is. So
Yes.
if all the directions are worsening, then I would again, yes, the question to the answer to your question is that I'll go back to my baseline. I would check my baseline accordingly. I'll take the decision whether it is truly worsening or not worsening.
Yes, that's good. And another question is, what is your management to reduce the pain without using the modalities? As you discussed in okay, that you are not using too much of electrotherapy. So, what is your
Yes.
approach to reducing the pain?
See, in my clinic, when I see that patients are responding to the exercises, I always give the exercise which is reducing the patient's symptoms. So I hardly give one or two exercises, and believe me, those are more than sufficient to reduce the patient's pain.
Okay.
What I have experienced is that when the patients comes to our clinic, we generally try to make our presence in such a way that yes, this is a clinician, he is going to give me 100%. And we think of doing in the multiple way that we try to give number of exercises, 5 exercises, 8 exercises, 10 exercises, strengthening exercises, and all. Patient is not actually looking for that.
Okay, okay,
I
fine.
have been
So,
giving a patient single direction exercises, and those direction patient gets better and they are happy, and they also feel better to do only one exercise throughout the, and they get the better result with that.
so it's all about the exercise prescription. So,
Yes,
whatever you want to
not
do,
about the
you are
number of
doing. Yeah.
exercises, it's about the perfect exercise.
Yes,
That's
yes,
what the
perfect.
directional preference is.
Yes, yes. So it's take away about to reduce the pain, find out the in which moment the patient has a relieving factor that you have to implement, and that will help you to improve the outcome as well.
Yeah.
So
So the McKenzie also helps to get to know कि वो कौन सा exercise,
yes,
which will
contact.
be that exercise that is reducing the pain.
Yes, yes, fine. Okay, so fine. Right now there is no not much questions. So thank you so much, all of you. We'll meet next Friday, and don't forget to visit my website proactivephysioknowledge.com, and don't forget to download the application from the Android store. So I'm signing out again. Thank you so much, Dr. Chandrakant, for your valuable time. We'll meet soon for the upcoming session regarding the McKenzie approach. Thank you so much.
It's my pleasure, Doctor.
Yes.
It's my pleasure, Dr. Jaimin.
Yeah.
Thank you so
Thank you
much
so
for
much.
inviting.
Thank
It
you
was
so much.
nice talking to you.
Nice.
Thank you so much. Good night.
Good
Take
night.
care. Bye.